My name is Carl K. I'm a captain in the United States Army and third-year internal medicine resident at Brooke Army Medical Center in San Antonio, Texas. I've got a great case to expand your differential for severe hepatocellular liver injury. To introduce the topic, I'll begin with a brief discussion of Yersiniosis. Yersinia enterocolitica is a gram-negative bacterium that causes foodborne illnesses typically characterized by acute febrile gastroenteritis, associated with a variety of gastrointestinal and extraintestinal manifestations. This clinical illness is referred to as yersiniosis. Isolated febrile illness without gastrointestinal symptoms is very rare. Our case is a 33-year-old Chinese male with no significant medical history. He presented on multiple occasions to the emergency department with recurrent high-grade fevers associated with chills, but notably, no gastrointestinal symptoms. He had no recent travel, sick contacts, alcohol abuse, toxic ingestions, high-risk behaviors, or supplemental ingestions. Initial labs were remarkable only for a mild neutropenia with normal liver chemistries. CT of the abdomen revealed terminal ileitis and mesenteric adenitis. You can see that here in the first CT. Repeat liver chemistries showed gradually rising transaminases over the next 2 weeks, which peaked with an AST of 991 and an ALT of 1664, and he had a normal bilirubin and alk phos, as well as a normal INR. He was given a 14-day course of empiric doxycycline for suspected typhus fever, with resolution of his fever, and you can see the exact timing laid out here in the graph. In the setting of improvement of his symptoms, yet rising liver chemistries, he was referred to hepatology. Extensive infectious and non-infectious workups were unremarkable, and you can scan the QR code for the entire workup. As part of the workup for the terminal ileitis, we found positive serology for Yersinia enterocolitica IgM, IgG, and IgA. Ultimately, he improved with supportive care, and his liver chemistries normalized in 3 weeks, and repeat CT scan after 3 months shows resolution of the terminal ileitis. As we reflect back on the case, Yersiniosis is a great imitator. Here it masqueraded as a rickettsial illness, given the high rate of tick-borne illnesses in southwest Texas and concomitant laboratory findings. The tertian fever pattern mimicked malaria, given its demographics, specifically its age and Chinese background. The imaging findings imitated Crohn's disease and tuberculosis, respectively. While rare, Yersiniosis is known to have hepatic involvement. Much of what we know about Yersiniosis hepatic involvement is described in 2 Norwegian studies from the 1990s. In their reports, depicted in the right side panel here, there are very few cases of liver injury with AST and ALT 5 times the upper limit. Hence, the severity of the liver involvement in the masquerading presentation made this case very unique and a diagnostic dilemma. This case highlights the importance of a thorough workup for terminal ileitis and Crohn's mimics, which ultimately revealed a unifying diagnosis. With minimal confounding factors, antimicrobials that were started after liver involvement, and the improvement of liver chemistries while on the doxycycline, it is easier to attribute the severe anapteric hepatitis or yersiniosis rather than another infection or a drug-induced liver injury. Therefore, this case highlights an important addition to the workup for undifferentiated severe isolated hepatocellular liver injury. Finally, I'd like to thank my mentors for this case, Dr. Morales and Dr. Subramanian. And if any of this case was interesting, I'd highly encourage you to scan the QR code and peruse a little bit more on our case. Either way, thanks for